I have spoken on tibial pylon fracture. Now this week I'll be speaking on the pelvic fracture overview. So when you consider the anatomy of the pelvis, you must know that the pelvis is formed by two hip bones, that is two hip bones, sacrum and coccyx. The joints of pelvis are right and left sacroiliac joint, sacrococcygeal joint, and pubic symphysis. So this constitutes the pelvic bone. Now the anatomical position of the pelvis is such that the pubic symphysis and anterior superior iliac spine lie in the same vertical or coronal plane. So the pubic symphysis is this one, and the anterior superior iliac spine, they lie in the same coronal plane. Means the pelvic bone is tilted anteriorly. Now what are the parts of the pelvis? The parts of the pelvis can be divided into greater pelvis, which is this one, and the lesser pelvis. Now these two pelvis are divided by this pelvic inlet, that is inlet of the pelvis or pelvic brim. The pelvic brim is formed by posteriorly the sacral promontory and pubic symphysis anteriorly. And these are the two arcuate lines on both the sides. So that constitutes the pelvic brim or inlet of the pelvis. So above this inlet there is a greater pelvis, and below this inlet is the lesser pelvis. Now the greater pelvis is also called as false pelvis, which contains sigmoid colon and the coils of the ilium. And the lesser pelvis, which is also called as a true pelvis, has bony walls from all the sides. Now the lesser pelvis contains urinary bladder and rectum in both the sexes. It contains prostate, seminal vesicles, vas deferens in males, and it contains uterus, fallopian tubes, and ovaries in females. So these are the features of the bony pelvis. Now consider the anatomy of the pelvis once again. On the posterior side, the pelvis has got the sacroiliac joint. This is sacrum, this is ilium, and this is the sacrum. This is pubis, and this is the pubic bone. And the pubic bone, they are anteriorly joined by a fibrocartilaginous structure that is called as pubic symphysis. So posteriorly, the pubic bones are joined by posterior sacroiliac ligaments. The stability of the pelvis depends upon the integrity of the posterior weight-bearing sacroiliac complex. So this is a very strong sacroiliac ligament joint complex, and the stability and integrity of this posterior weight-bearing sacroiliac complex, that also decides the stability of the pelvis. Now the transport of the weight which occurs between the bearing forces from the spine to the extremities, that transfer of the weight which occurs between the bearing forces from the spine to the extremities, that transfer of the weight happens through the sacroiliac joint. So posteriorly there is a sacrum, on the both sides there is ilium, on the anterior side there is pubic bone, and which is joined by pubic symphysis. Now the pelvis is a ring. Now we can see that it is a ring where anteriorly there is pubic symphysis and pubic bone. On the lateral side there are ilium, and the posteriorly the ring is formed by sacroiliac joint and sacrum. Now, disruption of the ring in with forces of the accident can lead to disruption of the on the anterior side, that is pubic symphysis, and on the posterior side there is disruption of the sacroiliac joint. So when there is anterior injury, the force is on the anterior side, there occurs disruption of the pubic symphysis on the anterior side. Also, there can be fracture of the pubic bone, as well as there is disruption of the sacroiliac joint on the posterior side. So usually, as it is a the ring can break on both the side, that is anteriorly as well as posteriorly. So the anterior injury is usually associated with posterior injury. So if the patient comes to you, the anterior injury of the pelvis is obvious. You can see, you can notice the pain and swelling on the anterior part, that is at the site of the pubic symphysis. Also, it is noted usually on the X-rays, and there is a tendency to forget or examine on the posterior side, but usually the posterior aspect of the sacroiliac, that is sacroiliac joint, is also disrupted. So this posterior injury can be occult, and one must look always on the back of the pelvis. So if there is a posterior gap along with the pubic rama fracture or anterior injury, usually this posterior gap or comminution is an unstable injury. So the posterior fracture is always serious as compared to the anterior fracture, and this, if it is associated with posterior injury, it needs significant blood transfusion, which I will be elaborating later, and it also requires surgery. The posterior fracture with disruption of the posterior ring complex is a serious injury, as it leads to instability of the pelvis and can cause profuse bleeding. The resultant instability, if not fixed surgically, can cause late deformity, limb length discrepancy, and pain. Now, what are the types of the pelvic fracture? Now, this classification or the types of the pelvic fracture is very important. You can get a long question on pelvic rim injuries or pelvic fractures, and one must know the types, management, and the outcome of the pelvic fracture. Now, type 1 is anteroposterior compression. So, as the name implies, anteroposterior means from anterior side to posterior side, and there is a compression. So, the force is compressive force, which leads to fracture of the pubic rami. Also, it can be separation of the pubic symphysis pubis, which is also called as symphysis pubic diastasis. So there is a separation, there is a gap between the two pubic bones, and disruption of the pubic symphysis. This is the joint which is disrupted, and also there is disruption of the sacroiliac joint. So this is anterior-posterior compression. We also label it as open book fracture of the pelvis. Now, what is the treatment for this anterior-posterior compression, that is open book fracture? The treatment is close the book, that is closure of the anterior symphysis diastasis. Now, how to close this book? That is one by pelvic binder, or you can apply a sling across the two ileum and tight it so that the book can be closed. Surgery is indicated when the diastasis of the pubic symphysis is more than 2.5 centimeter. Now again, how to close the book? By surgical method. If the patient is not even on an X-ray, if you are not able to see the gap closing with sling or pelvic belt, in that particular situation, one must go for a surgical approach, and anterior pelvic surgery is done with external fixator or a plate which is applied to the pubic symphysis. So here we can see that the external fixator pins are placed on the ileum and the gap is closed by compression with the clamps. Or one can go with a plate. Now here we can see that there is a plate which is applied over the pubic symphysis. So this is anterior-posterior compression where we are closing the pubic symphysis diastasis, that is open book. Now what is the second type of fracture? The second very important fracture is lateral compression. So as the name implies, it is lateral and it is compression. It is not shear, it is compression. So the force is from the lateral side and it is the most common type of fracture and is usually impacted and not displaced. So because it is from the lateral side, it is usually impacted and it is not displaced fracture. So lateral compression has got a good prognosis and usually it does not require surgical fixation. So here we can see that the pubic bone is fractured from the compression force which is applied from the lateral side. Also, there can be fracture of the posterior ileum. So there is an anterior fracture as well as there can be a posterior fracture. As the fragments are not displaced, they are only comminuted. These fractures, they have good prognosis as compared to anterior posterior compression or vertical shear fracture, which is the third type of fracture. Now this is the third type of fracture, pelvic fracture, which is called as vertical shear fracture. Now please remember, it is a very bad fracture which usually requires surgery on the anterior as well as posterior side, and it needs lot of blood transfusion. The outcome of this fracture is guarded because of profuse bleeding, which I will be elaborating later. The initial external fixation may be needed to control the bleeding. So you can place the pins on the ileum and compress the fracture so that uh, try to reduce the fracture so that the bleeding from the bone can be stopped. So this is the vertical shear fracture. Or you can apply traction in the emergency room, which may reduce the vertical displacement of this pelvis. Also, it decreases the motion of the fracture site. And sometimes the pelvic binder can be useful to control the bleeding. So the vertical shear fractures are stabilized surgically by anterior method, that is internal fixation with plate. You can apply the plate here on the symphysis pubis and stabilize the anterior side of the vertical shear displacement. Now see this reduction with the clamps and reduction of the fracture and placement of the plate can be done. Now this is the plate which is applied on the anterior side. Now on the posterior side, usually it is done by fixing the sacroiliac joint percutaneously or some open method under C-arm guidance and placement of the cancellous screws, long cancellous screws. Now this is the CT scan picture of the vertical shear fracture which was treated with a screw across the sacroiliac joint. Now let me speak about pelvic fracture with bleeding. Now this is the very important aspect of the pelvic fracture. Now we can see that the pelvis is well supplied by these arteries which are coming from the sacral foramen, and there is a very important artery, that is superior gluteal artery, which is in the close to the sciatic nerve in the superior gluteal foramen. So above the piriformis, here is the piriformis, and this artery can be torn in pelvic fractures, especially on the posterior side. Now you can see that this is the SI joint. Supply the muscle from the on the gluteal side as well as the bone, ileum, and the hip joint also. Now this is the superior gluteal artery, and this is the obturator artery which comes here through the obturator foramen. Now the superior gluteal artery is responsible for the majority of the bleeding in pelvic fracture with arterial injury. Here we can see that if there is a fracture on this in this area of the pelvis, the superior gluteal artery can be easily torn, and it is usually in the vertical shear fracture there occurs lot of bleeding. Now, most of the bleeding in pelvic fracture is from the veins and the fracture itself. The fracture, as the bone is cancellous, it can lead to significant bleeding from the fracture side. Also, there are veins which are adjacent to the superior gluteal artery, and the artery itself can be torn. The hemorrhage is the most life-threatening complication associated with pelvic injuries. So that is the significant aspect of pelvic injuries. When there is high velocity trauma, like motor vehicle accident or fall from height, in that particular situation, the hemorrhage is the most life-threatening complication associated with pelvic injuries. Now, this hemorrhage occurs usually through the superior gluteal artery, and the approximately 10% of the patient will have severe bleeding from the superior gluteal artery in case of pelvic fracture. The severe bleeding usually occurs in fracture patterns that are highly unstable on both rotational and vertical forces, like vertical shear fracture, that is the type 3 fracture. So, in case of open book type fracture with vertical shear component, like displacement of the sacroiliac joint vertically and with shear forces, it can rupture the superior gluteal artery and lead to severe hemorrhage. The complete disruption of the anterior sacroiliac joint, as well as sacrotuberous and sacrospinal ligaments, and disruption of the posterior sacroiliac ligament can lead to open book type of injury and a vertical shear fracture like this with fracture of the pubic rami, as well as the disruption of the uh, sacroiliac joint. So this is the very unstable in both rotational and vertical uh, direction, and therefore it lead to severe bleeding. So, so the complete disruption of the anterior and posterior ligaments, these are the anterior ligaments and the posterior ligaments, and cephalo-posterior displacement of the fracture, that is pelvis, leads to severe bleeding. So, anterior-posterior compression or vertical shear injuries are consistently associated with a high risk of mortality from bleeding. So, these fractures, if there is anterior-posterior compression with disruption of the sacroiliac joint as well as vertical shear fracture, see this, the pelvis is shifted vertically and there is a shear force which leads to significant bleeding. The mortality rate is directly related to shock at the time of presentation. The patient can be presented to you with a severe shock, and it leads to significant mortality. Bleeding from the superior gluteal artery could be fatal. How do you treat patient with pelvic fractures and massive bleeding? Ringer lactate solution is preferred initial fluid replacement used to resuscitate hypovolemic trauma patient in shock. The hypertensive blood trauma patient is given initial fluid push with almost 2 liters of ringer lactate. The patient with, sometimes the patient can be having O negative blood. In that particular situation, we should be very ready and very vigilant to get the blood transfusion. If the patient is given 4 units of blood but remains hemodynamically unstable, then angiography and embolization of the artery is required. So that is an advanced surgical procedure one must go for to save the life of the patient. How do you treat patient with pelvic fracture and massive bleeding? Immediate application of external fixator is another method to control the bleeding, especially if the patient pelvic is unstable in external rotation. The abdominal and pelvic CT scan will clearly define the bone injury as well as the extent and source of the bleeding. Now again, the best treatment for pelvic fracture with bleeding is a blood transfusion with correction of hypothermia and coagulopathy. to save the life of the patient. With this, I thank you so much for patience listening. I'll be very happy to answer any questions regarding the pelvic injuries. Thank you so much.